In this chapter, we'll discuss nutrition and aging. So an introduction and some terminology. So we have gerontology, which is the study of normal aging, including factors in biology, psychology, and sociology. Geriatrics is the study of the chronic diseases frequently associated with aging and their diagnosis and treatment. And then senescence is the organic process of growing older and displaying the effects of increased age. So you're probably more familiar with quote unquote the term of going senile, and that comes from senescence. Now here we just have again a more classic dictionary definition of aging. So gradual change in an organism that leads to increased risk of weakness, disease, and death. It takes place in a cell, an organ, or the total organism over the entire adult lifespan of any living thing. There is a decline in biological functions and an ability to adapt to metabolic stress. Changes in organs include the replacement of functional cardiovascular cells with fibrous tissue. Overall effects of aging include reduced immunity, loss of muscle strength, decline in memory and other aspects of cognition, and loss of color in the hair and elasticity in the skin. In women, the process accelerates after menopause. And so as we're going through this, one of the things that's actually kind of interesting is, we don't actually know what causes aging. So we know that animals age, or I should say organisms age, but we're not actually sure is why they have to, right? They should be able to, in essence, continue to replace themselves. Your cells should be producing identical copies, but that's obviously not the case, right? And organisms do age, but there's some interesting theories about why aging occurs. Now looking at some aging terms for aging research, we have our young old, which is 65 to 74 years old, and about 1% of this age group is in long-term care. We have the middle old, which is 75 to 84 years old, and about 6% of this population is in long-term care. And we have the oldest old, which is over the age of 85, and 22% of this population is in long-term care. We also have our centenarians, which are people living to be older than 100 years, and supercentenarians, which are older than 110 years. So here, looking at some Census Bureau data, we can see an aging population. And so this is projected to be the population that is 65 and older. And so this is in millions. And so what you're going to see is, and what we're looking for is the gaps between these graphs. So for example, from 2010 to 2020, it goes up by 14.4 million. And then if we go to 2020 to 2030, we're going to see a gap. Let me do some quick math, and this should be just under 16. It's going to be 15.9 million. And then from 2030 to 2040, we see a smaller gap of 9 million and then 6 million. And so the size of the gap is because, again, what you see is this large population of baby boomers who's aging, but then the generations, right, become smaller in their gaps. So, but the big thing here, and the big thing for us as healthcare providers, is that in 2030 we're going to have a lot of elderly. There is a concern that long-term care, even hospitals, may be overwhelmed with chronic illnesses by the sheer number of people that now qualify for this, right, this over the age of 65 with these chronic health conditions. And then here, looking at our oldest old, and so again, what you're going to see is that, again, you're going to see this, it's the gaps in between. And so what you'll see is that for 2040 and 2050, when that group, again, no longer is over 65, but they're now over 85, so 20 years later, we again see those large step-ups. And so, again, it's not going to match up person for person, but again, with improved longevity and improved healthcare, more people should be living to that oldest old. Now here we can also see, so here we can also stratify the data, and we can look at it with, again, not just our ages, but now we're going to be able to look at it by race and ethnicity. And so here we have, so non-Hispanic, white alone. So we see our percentages versus that's projected. And so what you're actually seeing is, so again, you're seeing a decrease in projection, but this doesn't mean less people are living. This is percentage of the population. And so what you're going to see then is you're going to see improved healthcare and improved lifespan in the other race and ethnic groups as well. So what you're going to see then is you see that everyone else increased. So Black alone, Asian alone, Hispanic, of any other race all increased. So what you're going to see then again is that there's going to be, again with our elderly population, not as many non-Hispanic white alone, but then better health care and longer lifespans for all other racial and ethnic groups as things kind of even out. So again, we keep talking about this generational group, the baby boomers. So they're born between 1946 and 1964. So 75.8 million Americans were born, and this represents about 28% of the US population, with another boomer turning 50 every 7 seconds. And between 2010 and 2030, the elderly population of baby boomers is going to turn 65. And 26 states will double their older than 65 population by 2030. So you'll often see in public health this is referred to as the quote-unquote silver tsunami, because again you're going to see a very, very large number of the population turning this age group at the same time. So looking at Florida, the state of Florida has the largest percentage of seniors in the US. Everyone knows when you retire and you move to Florida. I mean, that's literally the joke of countless movies, but it's true. So Florida contains 683 certified Medicare and Medicaid nursing homes. And so now again, these stats, again, this changes every year, but so last I checked, so there was 82,720 available beds for skilled nursing, with approximately 87% of these beds full on average. Now the overall average Medicare 5-star quality rating for a nursing home in Florida is 3.3, which ranks 21st nationally. So it's kind of crazy that we have the most elderly population, but we're like right in the middle of the pack when it comes to how good we are at taking care of them, right? We're not taking very good care of them, even though we have a whole lot of them. Now, the Florida legislature developed a comprehensive legislative statute known as Chapter 400, which protects residents of nursing homes and related healthcare facilities and assigns the fines and penalties for not abiding by the laws of this statute. So again, this is how you care for them, how many nurses can care for one patient. So can you be responsible for 5 patients, 6 patients? Do you help feed them, etc.? Like all those rules and regulations, there is a Florida statute that determines those numbers. So looking at long-term care, so 7 out of 10 residents are women. Now again, this has to do with the fact that, for example, right, women live longer than men. And when you live long enough and you have changes in your health status, you end up in long-term care. So it makes sense that more women are there. 79 years of age is the average age upon admittance to a nursing home. Again, this is actually that's older than the average lifespan for American men. 40% of individuals who reach age 65 who will enter a nursing home during their lifetime. Now, again, it's not always permanent. Sometimes people are there for physical therapy or rehab to get stronger and then leave, so it's not always permanent. And then also looking at costs, though, right? The average cost is, in the mid 80s, right? We're looking at mid 80 grand to stay in a nursing home in Central Florida. So looking at some other statistics, we have 68%. This is the probability that an individual over the age of 65 will become cognitively impaired or unable to complete at least 2 activities of daily living, including dressing, bathing, or eating over their lifetime. 42% of individuals in nursing homes are experiencing some form of dementia. 38% of nursing home patients who will eventually be discharged to go home or to another setting. 10% of people who enter a nursing home will stay there 5 or more years. And 65% of people who entered a nursing home will die within 1 year of admission. Now looking at hospital readmissions, so again, the big thing that we see is that, again, people come to the hospital, they should get better enough, and then they can either go home to convalesce, they can go to a long-term care facility to convalesce. But again, right, there's that some of this has to do with the numbers of how people are moving around. So 40% of Medicare patients, so remember you care for the elderly and we aid the poor. So Medicare is for the elderly, Medicaid, right, is for lower socioeconomic status or the poverty, right, the poverty line. So 40% of Medicare patients who are discharged from hospitals are admitted to a skilled nursing or rehab facility to complete their recovery. So that's what's supposed to happen is, you don't need to be the constant tubes and monitors, but we need somebody to keep an eye on you while you're getting better. Now, in less than 30 days, nearly 1 in 5 of these patients will go back to the hospital. And so this revolving door rehospitalization from nursing facilities is a growing problem and a big concern. This makes the government very angry. This is people abusing the system. So Medicare cost for rehospitalized patients in 2006 was $4.3 billion, and in 2013 it was $17 billion. This is not all inflation. This is people not doing their job, right? This is, if I can discharge the patient early, I can save money. And then, of course, that didn't actually fix the job, and then they come back and there's still issues. So holding hospitals accountable, so the Patient Protection and Affordable Care Act of 2010, aka Obamacare, it doesn't just provide insurance, right, for those who can't get it through their jobs. It also specifically addresses this problem. And starting in 2013, it allowed Medicare to level financial penalties for hospitals based on their readmission rates. And so the prospective penalties and payment model changes based on rehospitalization rates and has forced many hospitals and nursing homes into taking action to reduce readmission rates, which is good. We should stop this revolving door policy and fix problems the first time. So looking at hospitals with higher than readmission rates, so again, we're going to be looking at financial penalties. So by 2013, right, the Patient Protection and Affordable Care Act allowed CMS to withhold a percentage of inpatient Medicare payments based on a hospital's aggregate Medicare payments for all discharges. So again, what it does is it looks at the hospital as a whole, looks at their readmission rates, and then begins withholding penalties. Now, again, they had to give people time to implement changes to prevent this from happening, but the penalties started at 1% in 2013, and by 2015 they were up to 3%. And I know what you're thinking, which is, well, that's, 3%, that's not a lot of money. It is when you're a $500 million business, right? All of a sudden, if again, 3% of your, I get it, doesn't seem like a lot, but when it's $15 million gone missing, hospitals take notice. So I know it doesn't seem like it's pretty severe, but for hospitals, this was a big deal. Now, that's not to say that hospitals are always the bad guy, right? There are some times, right, we need to consider what the long-term care facility is doing as well. So are they jumping the gun? Are they sending patients to a hospital they don't need to? So some questions for the long-term care to consider is, could this transfer have been avoided? Were there early warnings of a decline in the patient's condition? So could we have caught this earlier and done something instead of just sending them to the hospital when they're really sick? Could precautions have been taken? Could the nursing home have provided the acute care the patient needed? If you just need antibiotics for a UTI, you don't need to go to the hospital. I can just give you antibiotics at the nursing home. And how can we avoid rehospitalization next time? Again, is this a unique case? Is this a problem in process, etc.? So why is it important to decrease hospital readmission rates? So obviously there's a significant financial impact for hospitals due to Medicare and Medicaid penalties. And so hospitals will acquire a reputation for poor quality of care. Did you know in the ambulance in the US, you can say, hey, I don't want to go to that hospital. Take me to a different one. We also know that the stress of a transfer on a resident can lead to medical and emotional setbacks that can delay and extend recovery, right? This can be very disorienting to people. And again, residents are well known by their staff at their long-term care facility. Again, what happens is that you build a relationship, right? Long-term care is essentially the patient's home. So you'll know how Mr. Smith acts, and you'll know if Mr. Smith just seems a little off today, and you can catch it earlier and realize, hey, he needs a medication adjustment. Hey, he has a UTI and some confusion. And again, the staff that sees them every day knows what's normal and what's not. The acute care facility does not know those things. Now, again, especially with our long-term care, we're looking at an interdisciplinary team. And so a team effort is probably the most important factor in reducing hospital readmission rates from nursing homes. And so this came out of a statement made by a healthcare system, right, that specialized in long-term care. And so again, what we're looking at is a combination of physician, nurses, pharmacist, psychiatrist or psychologist, different therapies including speech, occupational, and physical therapy, social worker, the registered dietitian, and CDM working together, recreation therapist, and volunteers. So looking at nutrition and disease prevention. So again, we have our primary prevention with an emphasis on nutrition and health promotion and disease prevention. So this is eating right so you don't get heart disease. We have our secondary prevention, which involves risk reduction and slowing progression of chronic nutrition-related diseases to maintain functionality and quality of life. So this is changing the diet so the symptoms aren't as bad. And then tertiary prevention, so it involves case management and discharge planning. So again, how are we going to follow up with this nutrition care long term? So looking at body composition and things we're concerned with in the elderly. So we're looking at a fat mass and visceral fat increase and a lean muscle mass decrease. This is unavoidable, although we are looking at diet and exercise regimens to minimize this. And so what we see is what's known as, again, this is a refresher from last month, which is sarcopenia. And so this is the loss of muscle mass, strength, and function. And this is accelerated by age and by decreased physical activity. So what will happen is that someone's leg circumference will stay the same, but there's actually more fat and less muscle. And we're also concerned with sedentary death syndrome. So again, describes life-threatening problems caused by a sedentary lifestyle. So what we see is, again, this elderly population gets weaker and weaker. They become chair-bound, they become bed-bound, right? And they get weaker and weaker and sicker and sicker. So looking at some specific nutrition and health issues with the elderly, so looking at taste and smell. So we do see a sensory loss increasing with age, and age-related alterations in smell, taste, and touch can lead to poor appetite, inappropriate food choices, and lower nutrient intake. And so patients may be suffering from dysgeusia with altered taste, ageusia with a loss of taste, or hyposmia with a decreased sense of smell, which is what's contributing to this loss or change in taste. Looking at changes in hearing, we have presbycusis, which is a hearing loss associated with aging, and usually the loss is greater in a high-pitched tone range. So what you'll see is it's actually more difficult to, in essence, hear like children's voices. Decreased levels of vitamin B12 are associated with increased ringing in the ears and presbycusis, so that tinnitus, so that ringing as well as a loss of hearing. And vitamin D may have an impact on hearing loss. So these are nutrients that we're exploring. Looking at vision, so vision changes occur with age and are typically small and correctable with glasses, improved lighting, or large print. Now some specific conditions that we do have, so age-related macular degeneration. And this occurs when the macula, which is the center of the retina, degrades, and a diet rich in fruits and vegetables may help prevent this. Looking at glaucoma, so this is damage to the optic nerve resulting from high pressure in the eye. This is increased with hypertension, diabetes, and cardiovascular disease. We have cataracts, which is clouding of the lens of the eye, and so a diet rich in antioxidants can help prevent cataracts. And high sodium may increase the risk of cataracts. We'll talk more about this when we look at the chapter with hyperglycemia and diabetes, but we also have diabetic retinopathy. So this occurs when blood vessels of the retina leak and produce spotty hemorrhages, and this is a complication of uncontrolled diabetes. Looking at oral issues, so chewing and swallowing difficulty can lead to a compromised nutrition status, and the patient may need soft foods if there's tooth loss or if they wear dentures. And 30% of those 65 and older no longer have any natural teeth. And an often side effect, right, so partly aging but mostly due as a side effect to medication, is xerostomia or dry mouth. This is often caused by medications, and we may need to moisten foods. This is the use of things like gravies, sauces, etc. Looking at immunocompetence, so the immune response becomes slower and less efficient with age. T lymphocyte cell function declines. There's increased infection and cancer rates in the elderly. And it's important to maintain good nutrition status to promote good immune function. Looking at GI issues, so we have dysphagia. So this is a difficulty or dysfunction in swallowing. And so commonly this is due to a neurological disease and senility, and the patient may need thickened liquids or texture-modified foods. And we'll talk about the National Dysphagia Diet and with its different levels and how soon this is being updated. I'll teach you both. Looking at, we also have achlorhydria. So this is an insufficient production of stomach acid. And so sufficient stomach acid and intrinsic factor are needed for the absorption of B12. And older adults are more likely to suffer from constipation. So here I'm going to show you the National Dysphagia Diets. Now this actually has been updated. So this was updated November, December of last year. I'm going to teach you both and I actually have to get you a copy of the new dysphagia diet. I'm going to teach you both because most facilities have not yet actually transitioned. They're still using the old terminology, so you'll need this for supervised practice. And I also haven't heard anything official on the RD exam if it has been changed. So I'd rather have you know both sets of terminology and be prepared than to not have the updated, than to only have the updated information and not be prepared. So like I said, many facilities are still using this terminology. So we have dysphagia pureed, which is level 1. Foods are a pudding-like consistency and the food requires no chewing. Dysphagia mechanically altered, or level 2. Foods are moist and soft textured, ground or finely chopped meats. Breads, pancakes, waffles, and cakes are pureed. You may also see some mechanically soft, which is kind of like a hybrid diet that's not technically part of the national dysphagia, which will allow still bread and rice cakes. But again, it's not technically part of the dysphagia diets. And this does require some chewing ability. And then dysphagia advanced, which is level 3, includes most regular foods except hard, sticky, or crunchy items, with avoiding things like toast, pineapple, coconut, and raw vegetables, although shredded lettuce is okay, but like carrot sticks, celery, etc. Meat should be thinly sliced, tender, or ground, and this does require more chewing ability. So again, no sirloin steak, but, sliced turkey meat, good to go. So again, this is the old national dysphagia diet, and then I will be discussing, because it's very technical, the new terminology with you during our Zoom session. Like I said, the facility that I work at does not use the new terminology. Other facilities do not yet use the new terminology. It requires a reworking and evaluation of everyone's menu nationwide. Now, along with that diet order, you will also see thickened liquid consistencies. So you have thin liquids, which are thin, like water. Nectar, which is like fruit nectar, such as mango or guava nectar. And then so the biggest thing is that nectar still forms droplets. You have honey, which is the same thickness as honey. And the big thing is you can form a continuous stream from what you're pouring it to the cup you're pouring it into. So kind of like how honey always has that super long, thick stream that makes it honey thick. And then pudding or spoon-like, which again is even thicker, such as pudding. Now this is done with a starch, so the most famous brand is probably Thicket, and this can be used at the bedside. And you use this starch to thicken these liquids. Now, liquids can only be modified by a physician's order. Not even a speech therapist can actually change it. They just tell the physician what to change it to. That's specifically for quote-unquote upgrading, which is if you want to go from honey to thin, that requires a physician. If I go, I think this patient is choking, and I go from thin to honey, and then I call the doctor and go, look, I changed it temporarily, come and see what you think, right? Then you're doing it for patient safety. Again, while not encouraged, that can be done in emergency situations. You can quote-unquote downgrade it, but you can't upgrade it and give somebody something thinner. Now looking at our organ system, so again, you have what's known as the 1% rule. So a decline in all organ systems of approximately 1% per year after the age of 30. So cardiovascular disease is not really an age-related disease. Now risk goes up because of our behaviors, but cardiovascular disease is really not, it's usually due to lifestyle choices, not due to aging. Renal function declines with age but varies tremendously, and it declines approximately 8 to 10 milliliters per minute per decade after the age of 30. Looking at neurological function, so cognition, steadiness, reactions, coordination, gait, sensations, and ADLs all can decline with age. So again, we said on the interdisciplinary team that we had a psychologist or psychiatrist. So depression is frequently misdiagnosed or underdiagnosed, so this is why you've seen this change in composition and inclusion in interdisciplinary teams. And untreated depression can have serious side effects for older adults. So depression is associated with decreased appetite, weight loss, fatigue, compromised immune system, diminished pleasure from eating, and exacerbation of other medical conditions. And 33% of individuals in nursing homes are suffering from some form of depression. Looking at factors that affect the food choices of the elderly. So looking at why the elderly eat what they do and make their choices, this includes things like poverty, social isolation and depression, loss of spouse, physical disability, poor dentition, chronic drug therapy, GI disorders and malabsorption, disease and other pathological processes, alcoholism, and inadequate knowledge of nutrition. Looking at frailty and failure to thrive, or adult failure to thrive. So 4 syndromes are predictive of adverse outcomes in older adults. This is impaired physical functioning, malnutrition, depression, and cognitive impairment. And signs and symptoms include weight loss, decreased appetite, poor nutrition, dehydration, inactivity, and impaired immune function. And nutrition interventions are essential for reversing these symptoms. Now, we talked about this previously in the drug and food-drug interaction chapter, but again, specifically now we're looking at it more from a viewpoint of the elderly. And so polypharmacy, again, remember, is the use of 5 or more medications. So this is common in the elderly and estimated to cause the death of 100,000 older adults each year. Many medications are taken unnecessarily. And again, we're concerned about drug-drug interactions, drug-nutrient interactions. Again, increased side effects from taking more than 5 or more drugs. Again, there's obviously a high cost because these prescriptions all cost money. Associated with increased risk of falls. So again, what you're going to see is some of that confusion. They trip and fall. Associated with decreased quality of life. And a risk of poor compliance with the medications due to pill burden, which again is, if I'm trying to take 5 pills twice a day, right, that's 10 pills a day. It's very frustrating. So signs and symptoms of polypharmacy include fatigue or decreased alertness, constipation, diarrhea or incontinence, poor appetite, confusion, either continuous or episodic depending on the timing of the medications, falls, depression or general lack of interest, weakness, tremors, hallucinations, anxiety or excitability, dizziness, decreased sexual behavior, and skin rashes. Now, we spoke about this previously looking at the medication and drug-nutrient interaction chapter, but we're going to go a little bit more in depth on the Beers criteria. This was developed in 1991 by Mark Beers, who is a geriatrician, and it's been updated several times in 1997, 2003, and 2011. And in 2012, we have the American Geriatric Society updated Beers criteria for potentially inappropriate medication use in older adults. So we previously looked at the long list of drugs that had their known side effects and risk in older adults. And so again, that comes from that 2012 report. Again, in addition to the drug list, there's some actual general practices as well. But we're just kind of focused right now on the medication aspect and how it can affect nutrition, risk, organ function, etc. But this provides a list of medications that, again, that are generally inappropriate for people 65 and older, because it's believed that the risk outweighs the benefit. Of course, there are individual situations. So the 3 categories of medications is we have, so one is medications that are potentially inappropriate for older people because they either pose high risk of adverse effects or appear to have limited effectiveness in older patients, so they may not even work effectively. Our other criteria is some medications that are potentially inappropriate for older people who have certain diseases or disorders because these drugs may exacerbate the specified health problems. So if you have ongoing renal issues, this may then complicate how the drug works or have additional side effects. And then there are medications to be used with caution in older adults, which we should, in essence, always be cautious, but this drug is less likely to cause problems. So looking at factors that contribute to non-compliance with drug therapy. So again, we look at our Beers criteria, we provide certain medications, and we then wonder, right, why do the patients stop taking these medications, or why are they quote-unquote non-compliant? And so what we've actually seen, and again, you have to look at, so who's currently in this age group, and so you had a lot of people from the Depression era, right, so they grew up with limited resources, and so what you'll see is, so borrowing or sharing of medication, where again, they'll say, oh, well, hey, I take the same dose, or here, we'll split this pill in half, and I'll take 5 milligrams, and you take 5 milligrams. Could be things like cognitive deficits and memory loss, so just not remembering to take the pill correctly, the cost of the drug, Hoarding medication for future use. I can't tell you how many elderly patients I've met that are, well, you never know, I might not get my script on time next time, and so they'll only take half the medication, or they'll save some of the medication for quote unquote next time, even though they're going to continue to get new scripts. But again, this creates a certain mindset, so especially if they grew up during the Depression. Improper storage or transferring to another container. Again, you'll see the pill containers. Technically, they are against the law, but again, it's one thing if a 65-year-old patient has one and is pulled over by the cops versus like a 20-year-old. But technically, right, so changing containers is actually not allowed with medications. A lack of understanding of how to take them and time them. The number of medications becomes overwhelming and they get frustrated. Physical limitations, you'll notice that we now have pill bottles that have modified ways to open them because the child-proof containers are very difficult, especially with arthritis. Scheduling difficulties, transportation issues to the pharmacy, although this has been alleviated now with things like you can do mail order for medications, and using expired medications. Looking at age-related physiological changes that can affect drug efficacy or effectiveness. So again, decreased renal function, which is the single most important factor responsible for altered drug levels in the elderly. And again, remember, GFR falls approximately 1 milliliter per minute each year after 40. A decline in the efficiency of the mechanisms that metabolize the drug, so this is things like the liver and kidneys. Decreased salivation, gastric acidity or GI motility. Increased transit time, decreased liver function, and decreased cardiac output. So taking a look at quality of life. So this is a general sense of happiness and satisfaction with one's life and environment. And so health-related quality of life is the personal sense of physical and mental health and the ability to react to factors in the physical and social environments. And so the RD is responsible for implementing strategies to improve nutrition-related quality of life. Now looking at functionality in the elderly. So here again we're looking at the ability to perform self-care, self-maintenance, and physical activities, and this corresponds with independence and quality of life. Now remember, our activities of daily living include toileting, bathing, eating, and dressing. Now we also then have our instrumental activities of daily living, which is a little bit more complicated tasks that are things like managing money, shopping, using the telephone, traveling within the community, housekeeping, preparing meals, and taking meds correctly. And so we know that inadequate nutrition intake can have a negative impact on performing these ADLs. So again, to improve nutrition quality of life, we can improve quality of life and ADLs. So again, it all ties back together. Now looking at obesity in the elderly. So obesity rates have increased in all ages in the past 25 years, including older adults. And overweight and obesity can lead to a decline in ADLs and instrumental ADLs. And weight loss therapy improves physical function, quality of life, and reduces medical complications associated with obesity. But again here, right, we have to keep things in perspective. So when we're talking about weight loss, right, our goal is not physique based, right? Our goal is not, there's not a scale goal per se, so much as, right, is what we're trying to achieve, right, is we're trying to improve health markers and function. And again, what we can see is we can see significant health improvements, and so that's our goal, is a 10% weight loss over a 6-month period of time. And again, using somewhere between a 500 to 1,000 calorie deficit. And so again, what we're looking for is improved health markers, improved mobility, etc. Right? We're not just trying to continually chase an ideal body weight without a purpose. Looking at underweight and malnutrition. So older women over the age of 65 are 3 times more likely than men to be underweight. And frailty, often due to micronutrient deficiencies, especially in women, is present. Now, according to the text, right, so approximately 40 to 60% of hospitalized patients are malnourished, 40 to 85% of nursing home patients are malnourished, and 20 to 60% of home care patients are malnourished. So again, you can see there's a lot of work for dietitians to do. Now again, we remember our definitions for weight loss, right? So severe weight loss is anything over 5% in 30 days, greater than 7.5% in 90 days, and greater than 10% in 180 days. Now again, this is especially important in long-term care patients, as this has to be documented in the record and in the minimum data set, or the MDS sheets. Again, there's also going to be documentation for the intervention. So if you notice a patient is losing weight in long-term care, this has to be addressed by the dietitian. And then you'll also see, right, there's going to be a communication form for family, physician, and the resident, if applicable, right, if they're of sound mind, to be made aware of the weight loss, aka you have to do something about it, and you have to tell people about it by law. You'll then do monthly and weekly weights on the patient. And again, even though we have our official cutoffs, many facilities are still going to document anything more than 2% weight loss. Again, basically kind of as need to be monitored or keep an eye on this patient type of monitoring and documentation. Now here we see a list of possible interventions for weight loss. And so again, you don't do all of this for every patient, right? But what this is this gives you an idea of we're trying to determine the cause. So this is asking about meal preferences. This is providing appetite stimulants. This is changing the foods offered. This is changing the portion sizes. This is looking at medications and speech therapy. This is looking to see if they're depressed. But again, you don't do every single one of these for every single patient. But again, what you're using is you're using your best judgment as a clinician to say, well, based on what their caretaker has told me, based on what food service has told me, hey, they noticed that Mr. Smith wasn't eating. It seems like maybe he's having some chewing problems. Let me consult speech therapy. Oh, it turns out I'm right. I changed the texture, and the problem is resolved. So looking at nutrition screenings in long-term care facilities. So here we're focused on poor intake of food, fluid, or supplements, significant weight changes, abnormal lab values, the presence of pressure ulcers, if the patient is on nutrition support or receiving dialysis, and other relevant conditions or diagnoses including dysphagia, constipation, edema, dementia, terminal illness, diabetes, and total dependence on staff for feedings, etc. We can also do the mini nutritional assessment. So again, we've looked at this form previously, so this is the one developed by Nestle Health Science. So there's a short form has been validated, and there is the full mini nutritional assessment, which I know sounds redundant, full mini, but this does include screening and assessment, and this is one of the most commonly used tools in long-term care. Now height, again, you may not be able to get accurately as the patient may not be able to stand, or they may have shrunk with damage to the vertebrae. So you may have to either look at historical heights or do segmental height. And weight, making sure that if we're looking at weights, that we're subtracting the weight of the wheelchair if they are chair-bound, etc. So just make sure that there may be some different factors in long-term care patients. And again, BMI is only useful if we have an accurate height. So at the end of the day, right, we have to use our clinical judgment. So when somebody tells you their height or you see their height listed and you look at it and you go, something is clearly off, right, we need to question things and investigate them further. So here you can see the mini nutritional assessment, which we've looked at before. So again, this is just some basic screening. And here we have the mini nutritional assessment with the additional questions. So you can then see the non-short version. Here's the full version, which I know sounds redundant. There's also the determine checklist, which we've talked about before. So this is specifically for older adults. So this is not for this is why you don't usually see this in your acute care populations, because again, this is specifically designed for older adults and typically more in a long-term care setting. Now the way it works, so here is looking at what you score points for. So it's kind of like golf where you want a low score. So 0 to 2 is good. We just follow up for nutrition in 6 months. 3 to 5, right, is a moderate risk. And so we see what can be done to improve eating habits and lifestyle. And so then looking at, going to your office on aging and senior nutrition care programs, things like Meals on Wheels, senior centers or health departments can help. Again, follow up in 3 months. And then 6 or more is high nutritional risk. So again, we'd recommend the patient brings this checklist next time they see their doctor, dietitian, or qualified health or social service provider, and talk with them about problems that they may have. And again, looking at ways to improve their nutritional health with community resources, education, etc. So again, otherwise, nutrition assessment in the elderly is pretty similar. So again, we're looking at all of the same numbers on assessments that we would in our standard acute care patients. But one of the other things that you just look at, though, is looking more a little bit into food preparation. How much are they able to prepare? Food availability if they're living independently. But again, for the most part, it's pretty similar to your acute care patients. Looking at nutrition needs. So we know that metabolic rate decreases with age, and energy needs decrease approximately 3% per decade in adults. with absorption and excretion becoming less efficient with age. And studies show older persons do not typically meet their needs for calories, total fat, fiber, calcium, magnesium, zinc, copper, folate, and vitamins B12, C, E, and D. Now looking for energy, we can use the Mifflin-St. Jeor equation for the elderly. We can also use the DRI tables, and we've talked about this a little bit before, but you can see, so this is again here our chest physician's nomogram, which is 20 to 25 calories per kilogram for weight loss, 25 to 30 calories for maintenance, and 30 to 35 calories per kilogram, and this is for wound healing, weight gain, or dialysis. And again, for weight loss, you could also subtract 500 to 1,000 calories depending on what's appropriate. Now, what you don't want to do is use the 20 to 25 calories and subtract 500 calories, right? You do one or the other, but again, it just depends on your facility, which math you're more comfortable with. Looking at protein needs in the elderly, so we know that proteins are going to be higher due to a risk of sarcopenia and also a change in muscle protein synthesis. So we actually have to provide them more protein. So we recommend 1 to 1.2 grams per kilogram of normal is the normal amount for older adults. 1.2 to 1.5 is for moderate protein depletion, and 1.5 to 2.0 grams per kilogram for severe depletion. Now again, we also have to take into account though that we may be using a different amount if there is renal disease, and then we would be using something like 0.8 grams per kilogram. Now we do want to spread the protein intake throughout the day and not exceed 30 grams in more than one serving to again help maximize MPS. So again, just spreading the protein out, which most people do normally, but just in case. Fluids, we typically recommend still 1 milliliter per kcal, or 30 to 35 milliliters per kilogram if there's no cardiac dysfunction or renal disease. But with certain disease processes such as renal disease or dialysis and congestive heart failure, we may need to limit fluids. So next we'll move into pressure ulcers. So again, anyone can develop a pressure ulcer, but because of the factors that we've talked about previously, looking at protein needs, decreased mobility, and other issues the elderly face, they're more common in the elderly, but again, this is not the only population they can occur in. They can occur in anyone that's bedbound or not mobile, but most frequently in the elderly. And so these are lesions that are caused by unrelieved pressure resulting in damage to the underlying tissues, and they commonly occur over bony prominences, aka the pokey parts, with the buttocks, heels, or sacrum. And so the risk factors for developing a pressure ulcer include malnutrition, dehydration, decreased mobility, advanced age, and incontinence. Now we have what's known as the Braden scale to help predict pressure ulcer risk, and our category includes sensory perception, moisture, activity, mobility, nutrition, friction, and shear. And so this has to do with, again, the condition of the skin, how mobile someone is, and again, we have our score, and in this case, right, a higher score indicates less risk. So looking at our pressure ulcers, so we have stage 1, where the skin is intact with redness noted. And this is similar to if you've ever fallen asleep on your arms, like if you ever put your head down and you wake up and notice there's a mark on your face or your arms are bright red, that's a stage 1. Stage 2 is a partial thickness loss of dermis. So here we have a shallow open ulcer with a red or pink wound bed without slough. This looks like an open or ruptured blister. So again, it's very, very shallow, but it's painful, tender, and bright red. Our stage 3 is full thickness tissue loss with subcutaneous fat that may be visible. So we're going thicker, we're going deeper into the wound as it's thicker. And stage 4 is full thickness tissue loss with the exposure of bone or muscle that is visible or directly palpable and may include undermining or tunneling. So you can imagine on somebody's buttocks, right? So you would see a wound that is so deep you can actually see the ischial tuberosities, right, or all the way to the thigh bone, right, through the tissue. And so here you can see an example of our stage 1, 2, 3, and 4. And again, you can see with the graphics, right, how deep the wound goes through the tissue. Now we also have what's known as an unstageable ulcer. So here we have full thickness tissue loss with a depth that is unknown until the slough or eschar can be removed from the wound bed, in which case, right, this dead tissue has to be cut away to actually determine how deep the wound is. So we know a wound is there, but we don't know how deep it is. We also have suspected deep tissue injuries. Again, this would be unknown depth, and so localized area that may be purple or maroon in color, or again, an intact skin or blood-filled blister due to the damage of underlying soft tissue. So this is bruises that in essence could go much deeper. They could have damaged tissue underneath. Again, we think so, but we don't know so for sure. So again, we know that proper nutrition is important to promote healing, prevent infection, and prevent new pressure ulcers from developing. So again, we may need high protein, high calorie supplements or snacks, large portions of protein or fortified foods. So again, this is things like mashed potatoes, which can be fortified with non-fat dry milk powder to increase their protein content or additional calories. We want to provide a multivitamin, again, so especially if the patient's having poor PO intake. And then weekly weights, again, to make sure that, again, we're making sure that we're meeting nutrition needs and promoting growth and healing. Now looking at these increased calorie needs to support growth and healing. So we recommend about 30 to 40 calories per kilogram or 1.25 to 2.0 grams of protein per kilogram. The Florida Diet Manual says you can go a little bit lower at 30 to 35, 1.2 to 1.5. And the Pressure Ulcer Advisory Council actually has specific recommendations for protein based on the stage, along with calorie recommendations. Again, I'm not so focused on which number you choose exactly. As you'll see, there's not one particular answer. As long as you understand that no matter which of these systems you use, a patient with a pressure ulcer needs additional calories and protein, no matter what. Again, whether you use 30 to 35 or 35 to 40, that's okay. Again, it's just making sure that you know that we have increased needs. So now I'm going to show you something a little bit controversial. So despite the research, you will still often see these supplements routinely recommended with patients. Again, your preceptor may or may not, depending on when they receive their training. Again, it's their professional license that they are putting on the line, so let them make the final decision, obviously. But again, you'll see these recommendations for vitamin C and zinc supplements repeatedly, and the idea is that they are involved in collagen formation, but the research shows they don't actually benefit pressure ulcers. So we know that vitamin C, right, is required for the function of neutrophils and the immune response. It's part of collagen, and again, it's safe to give somebody 500 milligrams twice a day until the wound is healed, but again, it doesn't show any significant benefit. So it's not going to hurt them, usually, as long as we're not violating the dosages or changing anything, but it doesn't actually help the wound heal faster. And so the thought behind zinc is that fibroblast proliferation and epithelialization are impaired with zinc deficiency. We know that zinc plays a role in the immune response and collagen synthesis, but it currently looks like that zinc supplementation in individuals without a deficiency can impair immunity and contribute to delayed wound healing. And so this is thought to be because it competes, right, with the other 2+ charged micronutrients. So this is looking at it's going to compete with things like iron and copper, which are also playing a role in tissue healing. Now the safe dose appears to be 220 milligrams of zinc sulfate for no more than 14 days. But again, if they're not deficient, it's not really going to contribute to wound healing. So I still suggest you obtain a serum zinc level. And if they are deficient, then we would want to prescribe zinc. But if they're not, again, it's not really appropriate and doesn't provide any benefit. Other nutrients that may promote healing, and so again, we just want to prevent deficiencies. We don't need to do mega doses, include arginine, glutamine, vitamin A, iron, copper, vitamin E, and vitamin K. Now looking at supplements, and so providing additional calories, nutrients, protein for the elderly. So the CMS guidelines recommend improving intake via wholesome foods is generally preferable to adding supplements. So again, first we just want to try and convince people to eat food. Then we can try and use supplements if the food isn't working. So first we want to consult with the family to gain preferences. So again, it could just be we're not providing them the foods they're interested in. So find out what they actually want to eat. And if they're nonverbal, we can ask the family, hey, what do they always like to eat for their birthday, etc., etc. We can try snacks or whole milks before supplements. So again, just increasing calories. If we normally do fat-free milk, we switch to whole milk, we significantly increased calories without really changing their diet. But again, a food-first policy. Supplements are also very expensive, And, right, they don't always have the best compliance, so patients don't like the way they taste. They may taste, vitamin-y or metallic-y. So again, if we can do it with foods first, that is ideal. But there are times when supplements are needed. So if they are warranted, we want to obtain a physician's order for the specific amount, times, so that they can be documented. So again, I want them to drink 2 Ensures, 1 at lunch, 1 at dinner, and then record how much of them they're actually consuming. Or I want them to get an Ensure between breakfast and lunch and between lunch and dinner. And the other option is what's known as MedPass, which in essence is a very high calorie, fairly high protein formula. And so what we do is when you have to take all these meds, as we discussed on previous slides with things like polypharmacy, is that you'll take one med and then take a shot of this MedPass supplement. And then you take your second med and you take a shot of the supplement to swallow the pills. And so what that does is if I do that 2 times a day, 5 pills each time, I can get people to actually consume a significant amount of additional calories through supplementation. So again, when can we use supplements? So again, we said how to best use the supplements. And then when we use them is if we've liberalized the diet and we've put in food preferences. So I've let you eat what you want. I've given you more options. I've given you preferred foods. And it's still not working, right? So we have continued weight loss and our food choices aren't working. If the resident is able to consume liquids better than foods, now we could still try smoothies, milkshakes, etc., as long as we had the equipment. But again, sometimes it's just easier for them to sip on something than it is to eat more food. Or the patient doesn't like the modified diet consistency and refuses to eat the modified texture, or they're unable to meet their calorie or protein needs with diet and snacks alone. So giving you an example of some of the types of supplements used in long-term care. So these are a little bit different than what we use in acute care, which is like your Boost or your Ensure. So we have MedPass, which has 2 calories per milliliter, 2.5 grams of protein per 30 milliliters. Again, this is what you would take with medications. There's what's known as house shakes or mighty shakes, and these are about little 4 ounces, the little cardboard containers. They're about 200 calories and 6 grams of protein. Magic Cup, which again is for those that are on a modified liquid consistency, as the Magic Cup, when it melts into pudding. It doesn't become too runny. And then protein powder, which is really just a whey protein isolate, which contains 30 calories and 6 grams of protein. There's also liquid protein in the form of Prostat, which is hydrolyzed collagen, with 30 mils providing 100 calories and 15 grams of protein. Now we also again have those fortified or enhanced foods. So again, these still need a physician's order, but we have these standardized recipes that we've developed, and then what will happen is they're used consistently in the facility. And these are things like super cereals, cream-based soups, fortified mashed potatoes, cookies, brownies, or puddings that all have had additional calories, proteins, and fats added. So here's an example of a quote-unquote a fortified super cereal, and so this is how you would see the standardized recipe. So provides 5 6-ounce portions, and the ingredients, right, is going to be your oatmeal, your milk, your water, your non-fat dry milk powder, margarine, brown sugar, and sugar. And so again, here what we're doing is we're just significantly increasing calories with protein and extra sugar. So non-fat dry milk powder providing additional carbs and protein, and then the sugar, right, providing additional sweetness, and then the margarine. Again, here where our goal is to provide a much more calorically dense version of oatmeal. Now looking at menu planning for the elderly and for long-term care. So the daily menus are based on the RDAs from the National Academy of Sciences for adults 51 and over. And so again, we're still looking at a balanced meal plan with 2 or more cups of milk per day, 2 to 3 servings of meat, 3 to 5 vegetables, 2 to 4 fruits with at least 1 source of vitamin C per day, and 5 to 6 servings of whole grain or enriched bread per day, with then other food components to complete meals. And they do offer an HS snack, and this has to do with meal timing for regulation. Usually it's typically either fruit or fruit juice with then either a whole grain or enriched crackers, cookies, etc. So again, it's more of just having to meet the offering requirements, although they can do things with more protein like peanut butter, etc. Now looking at our different levels of dining, so we have independent dining, which requires no assistance at meal times. Assisted dining requires some level of assistance, such as setup or occasional queuing, and special accommodations if they're unable to see foods at meal times or to ensure that nutrition needs are met, so they may have vision issues, need to be reminded of foods. Dependent dining, they're unable to feed themselves and must be fed by the staff. And then we have a couple of different programs. So we have progressive self-feeding or restorative nursing program. So they currently have difficulty in feeding themselves, but it's expected that with consistent training, they should be able to improve their level of independence. So the idea is to get back to that independent dining. And then skilled therapy programs have needs which require that the speech-language pathologist or occupational therapist carry out feeding programs. But again, often residents are only in this program for a short period of time and then discharged to one of the other programs. So this was a specific issue with either occupational therapy, so either with swallowing issues, which is speech therapy, or occupational, so how to actually use the fork and knife, etc. But then ideally, right, they then go into these other programs with training. Now to help with that and advance these programs, we have adaptive feeding equipment. And so adaptive feeding equipment is used by residents who need to improve their ability to feed themselves. So the residents are evaluated by a therapist, and then the therapist obtains a physician's order for specific equipment. And this can be things like built-up silverware, dishes that have an inner lip, rocker knives, special cups, plate guards, etc. So here we can see different types of this adaptive equipment. So you can see the built-up equipment, which makes it easier to hold, especially with arthritis. You can see the plate guards or the built-up lips. So again, in essence, you can pin the food in the corner to make it easier to scoop. So if you've ever tried to eat peas, right, it's the same kind of principle where you need something to corner them against. Here we have the rocker knives, and then we also have the nosy cups. So again, the cup, this way, if you've ever tried to drink from something and your nose gets in the way, in essence, there's a cutout for your nose. So again, it makes it easier to tilt the cup without having to lean back, right, in the chair, etc., to try and drink liquids. So looking at Medicare benefits, so the Social Security Act of 1965 created the Medicare program to cover most of the healthcare costs for those over 65 years of age. And so Part A covers inpatient hospital care, some skilled nursing care, hospice, and some healthcare costs for a limited period of time. Part B covers outpatient care and other therapies like physical and occupational therapy. Part C allows private insurers, including HMOs and PPOs, to offer health insurance to those receiving Medicare, and Part D is most famous for covering prescription drugs. So again, what you'll see is sometimes if you're working in long-term care, there's kind of some finagling on how this is actually going to be billed. Now the Home and Community-Based Services Waivers Program, so this is Medicaid Section 1915, provides services to nursing home appropriate older adults to help prevent or decrease nursing home or long-term care institutionalization. So going back to the earlier slides, we saw that people were better nourished if they were home. So if we can delay people from getting into a long-term care and staying home, then ideally they'll do better. So this is the largest single payer of long-term care services in the country, and this can include things like dental, skilled nursing, meal delivery, case management, and environmental modifications like handrails, ramps, etc. to keep people homebound and not ending up in long-term care. Now looking at some regulations, so we have ACA, CMS, and DCF. So we have the Center for Medicare and Medicaid Services, and that's CMS, and this is the federal agency who's actually in charge of Medicare, Medicaid, and the state children's health insurance program. And then we have ACA, which is the Agency for Healthcare Administration. And so this is for Florida, and this is responsible for the administration of the Medicaid program, for the licensure and regulation of health facilities, and for providing information to Floridians about the quality of the healthcare they receive in Florida. So again, it's federal money, but then there's a state agency that disperses and controls that money and education. And then DCF, right, so especially for the elderly, so all abuse is reported to DCF, and there is the hotline number, so looking, again, for mandatory reporters. If there's any concern about the treatment of the elderly, right, this is who we would notify. Now looking at the OAA, so from the Department of Health and Human Services, so we have the Older Americans Act Nutrition Program. So this is the largest federally funded community-based nutrition program for older adults, and this provides congregate and or home-based delivery meals. And so each meal supplies about 33% of the RDAs, and these are available to those that are 60 and older and targets those in the greatest economic and social need, and provides nutrition screening, education, and counseling, as well as access and links to other community services. So congregate site is basically, right, we have, so Meals on Wheels probably people are familiar with where we deliver the meal. And then a congregate site is everyone comes to one location, we eat the meals, we socialize, we play cards. because again, there's more to eating together than just getting nutrients in our bodies, right? Getting the nutrients in is really not that complicated, but there's more to the experience. It's the socialization, it's the, asking about people's family, it's the trading stories, etc. So this still provides that opportunity, helps maintain people's ADLs, gets them out of the house, etc. Looking at SNAP, this is our Supplemental Nutrition Assistance Program. So again, operated under state and local welfare offices under supervision by USDA. So again, federal money with a state administrator. Serves less than 1/3 of all eligible older adults, which is the lowest of all demographic groups. So what we're saying is that the elderly do qualify for SNAP, but they often don't take advantage of it. And so there's a low participation rate due to the myth of only a $10 monthly benefit, the stigmatization of using SNAP, feeling that the application process is intrusive or complicated, eligibility confusion, mistrusting of EBT cards, and a lack of outreach. So again, there's a lot of bad publicity around SNAP when ideally, right, what it's doing is it's helping provide good quality nutrition for those that actually need it. Looking at other programs for the elderly, so we have the Commodity Supplemental Food Program, and so supplements the diets of eligible Americans with nutritious commodity foods. So remember, commodities is one of the ways that we regulate and stabilize pricing in this country. So for example, the reason why milk, right, so baby cows are born in the spring, so milk should be, $1 a gallon in the spring and $10 a gallon in the fall, in winter. But what happens is, as the price is stabilized, right, the government helps pay for shortages and or for overages, and so the price stays stable on milk. Now, the excess milk purchased, though, is converted into commodity cheese, right, which is then used in these types of food programs. So eligibility is for those over the age of 60 and those that are less than 130% of the poverty level. We also have the Seniors Farmers Market Nutrition Program. So this provides coupons to low-income older individuals to purchase fresh, unprepared foods at farmers markets, roadside stands, and community-supported agricultural programs. And so again, eligibility is over the age of 60 and less than 185% of the poverty level. And so again, this helps stimulate the economy with looking at local fresh fruits and vegetables at the farmers markets, as well as providing access to those foods for the elderly. So it puts money into the economy and helps older Americans. Now again, just as a review, so we've been talking about these terms, but just to make sure we're all on the same page. So we have our skilled nursing facilities. So these provide long-term care and rehab services for patients with significant ADL deficiencies, and nursing care is available 24/7. We have assisted living facilities, which provides personal care services in the least restrictive, most home-like environment. Nursing services, though, are not available 24 hours a day, but these patients still need assistance with one or more ADLs. And then independent living is for 55 and older, does not provide health care, but it's considered to have senior-friendly surroundings with social activities. So again, there may be group meals, there may be, movie nights, socials, etc. Now we also have our extended congregate care or continuing care retirement community. And so you've seen these grow in popularity, and especially here in Florida. So this is where we have skilled nursing, assisted living, and independent living all in one location. And so this is kind of like, in essence, the villages, which provides residents the ability of remaining in a familiar setting as they become more impaired or need more care for short periods of time. It's also referred to as aging in place. And so the average CCRC contains 330 units, which you would see is 230 independent or congregate living units, 40 assisted living beds, and then 60 skilled nursing home beds. And so again, you're independent living, and then as you have some issues and it may be a little bit more difficult for you to cook or clean, etc., we can move into assisted living, and then if we become more impaired, skilled nursing. Some other care or types of care that are offered by these facilities includes respite care, and so this is temporary care provided by a facility, and so if it allows, for example, a break or a vacation for the caregiver, and as part of the Medicare hospice benefits. So if somebody is being cared for at home, and so in essence a family member is serving as the full-time caregiver, then again, if they need a break, they can actually go to this facility. The caregiver then gets a break, but the patient continues to receive the care that they need. Now with hospice care, so this can be provided inpatient or outpatient. So again, this can be done at home, this can be done in a hospice center, this can be done in a facility. But basically, right, from a nutrition standpoint, we're focused on comfort foods and emotional support. And again, remember with hospice care, so we're really not focused on finding a cure, quote unquote, but instead we're looking at palliative treatments, right, which is improving patients' comfort. We also have dementia units or special care units. These can be assisted living or skilled nursing, and this helps better meet the needs of Alzheimer's dementia patients and provides protection for those without dementia. So again, you're looking at a facility that just has some specific design features and elements with, again, how secure the facility is, right? The patients are allowed to wander to help reduce anxiety, but it has to do with facility design and training of the staff. Some other examples include, again, so the overall facility is locked, but then there's allowed for continuous pathways for wandering, less need for physical or chemical restraints, safer environment for the patients that have dementia as well as those without dementia. There's less or quieter background noise, less TV, less announcements. An open floor plan allows for easy visual access, color-coded hallways. So again, if you know, like I live down the purple hallway, personal identifiable pictures next to the door, individualized care with different staff ratios, specialized training, and private dining and activity rooms. Now looking at the documentation, so this is especially when it comes to finding a job in Central Florida, looking at long-term care, as you want to be familiar with the MDS, which is the minimum data set. This is not the materials data sheet. This is the minimum data set. So this is developed by CMS and a federally mandated process for clinical assessment of all residents in Medicare and Medicaid certified nursing homes. And this tool, which provides a comprehensive assessment of each resident's functional capabilities and helps the nursing home staff identify possible health problems. And so what you do is, based on your documentation, it'll contain triggers that then indicate a patient's at nutrition risk and requires intervention. Now again, that's for our aspect. Other therapies will complete their aspects. So the care area assessments are part of this process and provide the foundation upon which a resident's individual care plan is formulated. So MDS assessments are required for residents on admission, so when you first come to the facility, quarterly, so 4 times a year, or if any significant changes occur, such as weight loss, and upon discharge. So all assessments are completed within a specific guidelines and time frame. So technically you have up to a week usually, but almost everyone does it sooner. In most cases, participants in the assessment process are licensed healthcare professionals employed by the nursing home. And again, what we're completing is Section K, which is the oral and nutrition status. And so this MDS information is transmitted electronically by nursing homes to the National MDS database at CMS, which is we complete these screenings and forms. They are then sent to the federal government because, again, somebody has to hold us accountable and make sure that nursing homes are doing their jobs, especially if they're going to be receiving federal funds. So here you can see Section K, which has to do with swallowing, height and weight, any weight loss, any nutritional approaches that are being used, and then if the patient is receiving artificial nutrition, how it's being done with the tube feed, etc. So again, we complete this information based on the results. If there's any triggers, right, we then have to show a treatment plan, which is part of your documentation process. And then again, right, this is then sent to the federal government for review. So looking at care plans, so Regulation 483.2 in the Florida statute states, the facility must develop a comprehensive care plan for each resident that includes measurable objectives and timetables to meet a resident's medical, nursing, mental, and psychosocial needs that are identified in the comprehensive assessment. So again, you have to do a nutrition assessment, and then for all the problems you identify, you must create a plan to correct them. So the guidelines for developing these care plans, again, must be completed within 7 days, but again, they're usually completed much sooner. Individualized care plans, you can't just rubber stamp and give everyone the same plan. Focusing on assessed problems of potential risk. So again, if there's a problem, you have to actually address it and fix it, which is why we talked about our specific goals and interventions. Provide clear and concise problem statements, which is your PES. Involve the resident or family in the process, and involving other members of the IDT team. You'll actually have quarterly meetings about each patient, using appropriate goals and objectives. And care plan meetings must be reviewed on a quarterly basis with the resident and or family, and must be attended by all members of the IDT. So a lot of times in long-term care, you spend probably the first half of your day in meetings to review patients, make sure everyone's on the same page for what's being done to treat and help that patient. You'll also see the ombudsman program, so you're going to see these in your long-term care facility. So an ombudsman's a volunteer advocate for people who live in nursing homes, assisted living facilities, and adult family care homes. Now, again, the idea is so that these services are confidential and free of charge. And so their duties is to provide a voice for those who may not be able to speak up for themselves. They advocate for patient rights. They investigate and resolve the concerns or complaints of residents and their loved ones, and provide an annual assessment of all facilities. So in essence, what this is somebody who is now, right, that is their professional job is to watch out for the residents, and they may do things anonymously where, if residents are concerned about reprisals from the staff, but in essence, they help investigate things, they report things if they need to be reported, right, and they serve as a liaison between the staff, right, and the residents to make sure that the residents' rights are being respected. Which is actually, it's a really cool program, but again, there's not the financial incentive, to be manipulated or kind of cheat the system. Where again, it's really doing this to help benefit, right, those that are less able to care for themselves. Looking at nutrition support in long-term care, so determine if a resident has advanced directives. Do they even want nutrition support, which is the first thing which we've discussed previously. And then conditions in long-term care that may warrant this nutrition support includes things like strokes, dysphagia, chemotherapy or radiation treatments, depression, persistent vegetative states, or end-stage dementia. Looking at dialysis in long-term care. So again, patients may either do it on-site or they may actually go off-site. And so monthly follow-up should be done by the RD. And so again, they need to be in contact with the dialysis center and document that this occurred. So they need to speak with the RD if possible, get a copy of the labs from the dialysis center, and make sure they're aware of the patient's dry weight so it can be monitored at the long-term care facility. So the average fluid gain between treatments, right, we want to make sure they're not gaining more than 1.5 kilos, so you're looking at about 3 to 4 pounds. And again, a need for a fluid restriction and or protein supplement while at the long-term care facility. Again, we're also still responsible for meeting the nutrition needs, so they'll need to be sent a bag lunch of appropriate foods if they are going on the days they go to their dialysis treatments. And again, they may also need to be sent their medications, for example, phosphorus binders, when they go to their treatments. Now, some of that's nursing's responsibilities, but just to give you an idea is that if it's a nursing home resident, that nursing home is responsible for all of those patients, their meals, their medications, etc., even if they go off-site. So looking at end-of-life and palliative care, which we've talked a little bit about. So palliative care provides patients with relief from the symptoms, pain, and stress of serious illness. And the goal is focused on the optimal quality of life for residents and families by management of physiological symptoms, as well as psychological, social, and spiritual issues. And so again, palliative care is for a person of any age, whether or not their illness is terminal. Now, what you'll see, though, is that if the illness is terminal, we may only be performing palliative care, but palliative care is that overarching philosophy focused on making someone feel better, right? Symptom relief, pain relief, etc. And then hospice care is a type of palliative care for those who are in the final weeks or months of life with a terminal illness. So all hospice care patients are receiving palliative care, but not all palliative care patients are on hospice, if that makes sense. So looking at nutrition interventions for palliative care. So nutrition therapy is focused on resident enjoyment, relief of symptoms, and maintenance of energy and strength, often providing comfort foods, whether this be favorite foods or preferred foods. Again, the family can bring food in. We want to make sure that we're honoring food preferences, giving people a liberalized diet, right? If somebody's got, 6 months to live, what are you gonna, you can't have salt. What's it going to do? Kill them? Right? We need to understand, like, keep things in perspective. If that's something that somebody really wants, and you know what, this food would just taste so much better with some salt, let them have it. My goodness. We know that small, frequent meals are often better tolerated. We want to make sure that we're not pushing food excessively. So again, if they want to eat, perfectly fine. If they're less hungry and they're eating less, again, that's also okay. We want to monitor the residents' likes and dislikes as tastes and preferences can change, especially with changes in medication dosages. So they may all of a sudden what they used to like not like, or vice versa. And important that we have clear and advanced directives regarding hydration and nutrition. So should the worst happen, what does the patient want us to do? Did they write this down, etc. Now looking at ethical and legal issues in nutrition and hydration and feeding. So this is from the Academy. So the position paper says individuals have the right to request or refuse nutrition and hydration as medical treatment. RDs have an active role in determining nutrition and hydration requirements, and also in a professional role in the ethical deliberation around the decision of whether or not to provide artificial nutrition and hydration. The RD has responsibility as a member of the healthcare team to promote the use of advanced directives. And in some circumstances, nutrition may be considered futile as a medical treatment, as the ultimate goal of any medical intervention should be improvement of the patient's prognosis, comfort, well-being, or general state of health. And all that's saying is that sometimes, right, giving nutrition, for example, giving someone fluids may actually make their condition worse, right, especially if they have congestive heart failure or other lung issues. So again, we have to be advocates for, again, what's best for this patient at this time and respecting their wishes. Here you just see a sample of PES statements that might be used. So here we have things like difficulty chewing, so because the patient has no teeth, difficulty swallowing, unintended weight loss, inadequate intake, increased needs, etc. Inadequate fluid intake, involuntary weight loss, altered labs, excessive weight gain. Again, what we're looking at is specific symptoms, and again, what can we resolve as the dietitian, right? So if somebody has inadequate weight gain, or they, inadequate intake, or they have weight loss, and we want them to gain weight. Again, for example, if it's because they're depressed, right, that's going to be more of a psychological issue. But if it's because of their caloric density or their food choices, or they're not able to eat the food, right, that's more of a nutrition issue. So again, just making sure that it has a etiology that we can fix, right? So there's nutrition symptoms with something that we can actually improve with our diagnosis. Now you'll also hear about, so these are F tags, these are things that have to do with regulation within a long-term care facility. So these are things that dietitians play a role in. We're not exclusive to this, and we're not the only people that play a role in this. This is more of part of the entire facility. But these are things that dietitians may be involved with, or they may have to identify or correct specific issues. And so here we have, again, so these are other things like dignity, which has to do with things. So for example, the dining hall itself, the type of music played, the height of the tables, making sure that, right, that a patient's chair is adjusted so they're sitting at the table appropriately. There's lots of little things that have to do with patient care that, again, dietitians are involved in, even though you may not realize their direct involvement. But the facility and the dietitian, right, everyone is still responsible as part of the team. So looking at the RD in long-term care, so the RD who works in long-term care has more opportunities to impact the resident's nutrition status. So again, you're really building a relationship with these patients. You're going to see them for long periods of time. You'll know if something's wrong. If you actually want to do education, you see these patients on a much more consistent basis. So if you want to look at long-term behavior changes, it's actually very different than acute care, right? There's more time to monitor their response to an intervention, so you actually get to see if your interventions worked as opposed to just a Band-Aid. You're providing the follow-up care. You're participating in their daily meetings. So if you go, look, something's just not right with Mr. Smith. He really needs to be seen by occupational therapy, physical therapy, etc., right? You're really there advocating for the patient and seeing the changes, how they're doing, right? If something needs to be addressed. Whereas acute care, you're kind of putting a Band-Aid on it and you never see the patient again. And if this is something that you're interested in pursuing, there is a board certification. So that's a certified specialist in gerontological nutrition, which again is going to be focused on, again, caring for the elderly and their disease states. And I can tell you it is also, for those of you that are curious, well compensated. All right, so let's take a look at some practice questions. So secondary disease prevention consists of, and this is answer choice B, risk reduction and slowing the progression of chronic diseases. Number 2, aging is associated with, and this is answer choice A, a loss of muscle mass, right? This is referred to with aging as sarcopenia. Number 3, risk factors associated with the development of pressure ulcers include, and this is answer choice B, incontinence and being underweight. So again, this goes back to the Braden scale. Number 4, the screening tool required in long-term care facilities by the CMS and this is answer choice A, the MDS. So you will also possibly still use the MNA or the determined checklist, but that is based on a facility or a company policy. The federal government requires the MDS, again, as the bare minimum. In older adults, symptoms of confusion, weakness, fatigue, or frequent falls are often caused by and this is dehydration. Thank you for your time, and I look forward to your questions.